All right. Hey, afternoon, everybody. I'm Steve Jaffe. I chair medical ethics and health policy and help coordinate this program, this REPS lecture series with Holly Fernandez Lynch, who's away at a conference today. Today, it's my pleasure to welcome Dr. Katie Auriemma for a lecture titled Returning Results to Participants in Pragmatic Trials. I'll be talking more, introduce her further in a moment, but let me say a few words of introduction. First, our next lecture is going to advance the slide. These are the lectures that we have had. This is coming to the end of our spring season. We will take a summer break in July and August, and then reconvene in September with a really great program of lectures for the fall, starting with Dr. Seema Shah from Lurie Children's Hospital in Northwestern, who's going to be talking about ethical issues in infection challenge trials, actually infecting people in order to learn more about the biology of the infection and to test interventions. Then Dr. Eric Turkheimer, who's a very prominent psychologist from University of Virginia, who's going to be coming to talk about socio-behavioral genomics, the idea of like using genomics to develop predictors or correlates of intelligence, of social functioning, of things like that. He's a critic of the ways in which genomics has been used and is probably the leading critic out there in the world. It's going to be a very interesting lecture. Then in November, Dr. Rebecca Ahrens-Nicholas and Dr. Karen Musunuru, who have become famous for their work with baby KJ, are going to be coming to talk about their work on that. And finally, in December, Ann Coppola from medicine is going to be talking about misinformation and communication about science. So it should be a great program. We always, Holly and I always invite your suggestions, your ideas for speakers, people from Penn, people from outside Penn, topics that you want to hear about that's relevant broadly to research ethics and policy. So please feel free to let us know. Just reminding you, some resources, online resources from our department related to research ethics and research regulation education, a series of short research ethics courses available for continuing education credit for those of you who need that. And some of them can also be used to satisfy research ethics training, like city requirements for Penn and CHOP. And finally, or almost finally, a thank you to our co-sponsors who are listed here on the slide, and a particular thank you to Lisa Bailey, who coordinates this program. And actually, finally, there actually is a lecture or something going on in this room immediately after we finish. So I would just ask that at 1 o'clock when we finish, that everybody please get as quickly as possible so that the room can be turned over to the next group. Now, let me introduce Dr. Katie Auriemma. Dr. Auriemma is an assistant professor of medicine here at the Perelman School in the Division of Pulmonary and Critical Care. She got her medical degree from Penn and then did an internal medicine residency at University of California, San Francisco, where she was chief resident. Then came here for her pulmonary and critical care fellowship, as well as a master's degree in health policy research. She joined our faculty in 2022, 4 years ago, and her research focuses on improving the value of serious illness care by better aligning interventions with the values and preferences of patients and their families. She's funded by a Career Development Award from the Heart, Lung, and Blood Institute, building a research program that approaches this goal in multiple complementary ways. So with that, looking forward to your lecture, Dr. Auriemma, on returning results to participants in pragmatic trials.
Thank you. Thank you so much. Thank you. I'm delighted to be joining you all. It was fun to take the fancy elevators on the other side of the building, so it's already off to a great start. Thank you so much to Steve and to Holly for inviting me. I really appreciate this opportunity. This is a new talk, and so I welcome questions, of course, but comments, criticism, thoughts on how we can think through this topic together. And I've built in a couple opportunities throughout for us to maybe pause and have a discussion. But of course, also there'll be time at the end. All right, so why does this matter? Why are we talking about this at all? Funders are increasingly expecting investigators to have a plan for returning results to research participants. Here's some language that comes from two of the big funders in the space, NIH and PCORI, where NIH is actually working to make this responsible return of research results standard practice. And they have sort of a whole site now where they're like sort of pulling out why they want to do this and how they're hoping that this will be accomplished over the next 2 years in particular. And it'll eventually probably become part of our proposals that there's a plan for this. PCORI for a long time has encouraged investigators to make every reasonable effort to return aggregate study results to participants, and this is something that they also expect in their proposals. And if anyone has recently closed out an IRB in our own system, what you will see is that when you do close this out, it's a little small, but we just came upon this the other day, is now when you're finishing a protocol that you've completed all the work, our own IRB is asking us, what is your plan for how you're going to either disseminate or return results to the people who participated or the communities from which they come? And so this is something that we're all going to need to think about in various types of research and including pragmatic trials. All right, so has anyone done this before and how has it gone? So one example of a pragmatic trial in which results were returned and it maybe did not go the way that they wanted it to. So this was a quick, just a quick summary of what it was. This was an open label study of all patients being seen by an urban emergency medical system in the community who required sedation for either agitation or for delivery of medical intervention. And they randomized by individual if they were going to receive haloperidol versus ketamine. And subsequently, they sent out letters to the individuals in the community that sort of were basically this form letter that said, you've gotten this, you were in this study, you got this stuff, here you go. Huge backlash. So multiple stories that took this on. This was published in multiple press things about how there's an eruption of controversy about this health system experimenting on people, treating people like guinea pigs, like really that feeling of massive distrust when people were in this very vulnerable position to be having this kind of what they felt was unfair randomization to what they felt was not something that they'd consented to. They clearly hadn't, based on the way the study was designed. It is not a mystery, right? Or it is not a surprise that we are currently facing a crisis of trust in science and medicine. It's interesting to see that there's going to be a talk on that later this year, because clearly this is something that we're facing in a variety of fields. And, you know, getting this wrong, like the return of research results from pragmatic trials because of variations in the way they are implemented really could exacerbate an already really significant problem with the science and trust in medicine. So just wanting to make a point that this matters, and we have opportunities to figure out how to do this well. And if we don't, we might end up in scenarios where what is already a problem becomes even more of one. All right, so our outline for today is, should investigators return results to participants in pragmatic clinical trials? To whom should results be returned? And how should results be returned? So I maybe said this at the start that we'll have some opportunities for discussion, because I'm going to just disclose right now that we might walk away with more questions than solid answers. And so just know now that we as a group can think about this together, but we might not have all of the concrete answers by the time this talk is done. So quickly, what are pragmatic clinical trials? And so I gave you one example of one in the earlier part of this talk, but in general, pragmatic clinical trials are studies that are designed to evaluate how well an intervention works in the quote unquote real world routine clinical setting. This here is the Pressey wheel that sort of gives the domains of what might be done in a trial, and that you can rate how pragmatic or not each of those components are. So things, for example, like eligibility, who's selected to participate in the trial. The most pragmatic trials have maybe very relaxed criteria. It can almost any comer can be part of the trial. And then more explanatory focused trials might have that be a much more narrowly defined population. And you can think about that on all of the various domains that are shown on this wheel. Oftentimes, pragmatic trials are sort of shown on this continuum where the other end is these explanatory trials, where the question is, does the intervention work under ideal conditions? The idea is you're trying to get towards efficacy, compared to pragmatic trials that are, again, under that routine real world practice scenario. And what you're trying to get at is effectiveness. There are lots of different pictures and diagrams that sort of try to distinguish the differences between these two. But, in general, like the takeaway point is that pragmatic studies are often being held in clinical scenarios in which the comparison are all things that are part of routine care. So you're usually not doing something that is very experimental or in which we don't typically see it in part of standard practice. We might not know if this version of standard practice versus another is better, and that's why a trial is being done. But it's not necessarily something that has never been used before that someone would be shocked to find out you would use in that clinical scenario. So should investigators return results to participants in clinical trials? So pragmatic clinical trials in particular. So that's what we're going to talk about. So there is a number of different ethical principles that would suggest we ought to be returning results to participants in clinical trials. There is respect for persons' autonomy. Participants in trials are contributing their time, their information, their data, and sometimes they might be accepting some degree of risk. This is generally true for other types of research. And this idea that you would return results to them really recognizes those participants as partners rather than just subjects in your study or rather than just sources of data. It also supports autonomy by giving people information that might matter down the road to their lives, their health decisions, or their future planning. That's especially true in, I think, the first set of studies that came out that really, where the history of returning results came out, which was really genetic studies, where it was like this genetic information like might be important to you down the line, and so you should have it, you should own it. Pragmatic trials different, but sort of there's some overlap there in terms of thinking about respect for persons. Reciprocity and fairness. So participants, again, they contribute altruistically with generally little benefit to themselves. And so returning results is sort of a form of acknowledging their contribution. This is also true in the context of aggregate results. Like, so you can reciprocate by giving people the aggregate data or the aggregate summary of what was learned from their participation in the study. Beneficence of potential clinical utility. The potential clinical utility may or may not be as related to pragmatic trials as, say, trials in which you're getting specific, say, genetic information or biologic information on an individual, but there's still the possibility that if you know that an intervention ultimately proved to be better than the other in a study, perhaps that would influence the care that a patient might seek down the line. Transparency and trustworthiness. So it is thought that returning results could improve trust between researchers and participants, between the public and the scientific community. This is especially true. Like, there is some data about this, and we'll go into it in a little bit more detail of where that comes from. There's not a lot, and it's really not primarily from pragmatic studies. It's mostly from explanatory studies and studies in which individuals opted into participation. There is also a little bit of data that transparency may improve willingness to participate in future studies down the line. All right, participant preferences and expectations. So this is also one that's there. So there's multiple empiric studies that have consistently shown that participants who know that they're part of research want to be made aware of the research findings. This is generally something that comes up all the time. I will say in our own studies, like my team's research, where we've done prospective cohort studies and observational work, what we've essentially found is that we hear this all the time from people. These are just a few comments from studies of studies that included participants that knew that they were voluntarily participating in the research, just expressing how they want to know, whether it's really related to them in particular or more, they want to know the big picture. They want to know how the time, the effort that they may have contributed could pay off down the line for others. And they want to know what the big picture is. There's also a thought that returning research results could benefit the research enterprise. Like, it might be good for all of us too. Again, we said increased trust, potentially greater willingness to participate now. So if you are notifying someone of participation in a study and you're going to let them know the results of it down the line, maybe they're going to be more likely to engage and with whatever follow-up might be coming down the line. Perhaps improved retention, again, in studies in which people know that they're part of it. Stronger engagement during the study. If they know that they're going to ultimately get to sort of see what the fruits are of the labor, maybe they're going to be more likely to put the time or the effort into doing whatever study follow-up you might have. And then again, maybe more positive attitudes towards future research participation and the possibility of wanting to being willing to enroll in future studies eventually. And that's this, that leads into this thought that there might be this virtuous cycle, that if we sort of think about subjects as actually partners and we're sort of learning information because of their time, effort, sometimes biologic samples, and we return those results to those communities, maybe they're going to be more likely to want to engage with us, and we really can sort of move knowledge forward as a team as opposed to researchers studying other people. And then I think these two pieces might be even more relevant to pragmatic studies that are delivered through health systems and in regular world clinical practices. Could there be greater job satisfaction if we do a better job of returning results to individuals involved in research studies, who often are the clinicians who are involved in the interventions of a pragmatic study? And maybe that could down the line lead to increased workforce retention. Who knows? We don't know that those things are true necessarily, but maybe they are, and it could be something worth trying to figure out. All right, all of this mostly comes from a small body of literature that's primarily built around explanatory trials, not really pragmatic trials. And most of the time, when you think of an explanatory trial, this is going to be a very simplistic sort of timeline of how a study goes, is you identify and you recruit specific participants. You recruit them, you talk to them, you invite them to participate in your study. You get consent from them. You tell them about the study. You tell them what the risks, benefits, alternatives might be. And then if they choose to participate, they do so voluntarily. You then conduct your study, whatever that might be. You obtain and then you analyze your results. And maybe, like, again, it doesn't happen a lot of the time, but maybe you then decide to go back and share those results with your participants, hopefully. And in theory, all of that is like that type of process is what all of that evidence I was telling you about in terms of it building trust or building engagement comes from, studies that sort of function like this. But how might this process differ in the context of pragmatic clinical trials? So we're going to talk about a couple specific pragmatic clinical trials. So I'm going to tell you about 4 real trials, and then we'll kind of think about, as we go through this as a group, like what's different, and therefore why might that prior body of evidence not apply, and what might alternative consequences be of returning results. So this is a trial that is being led by Shivan Mehta here at Penn, and this is about promoting colorectal cancer screening. So among individuals at average risk of colorectal cancer, they are randomizing on the patient level to either receive a sort of direct information to the patient or direct information to the patient and the clinician to try and encourage different types of colorectal cancer screening. And there are some behavioral science sort of ways built into that too, like different types of ways of sort of expanding the choice set and types of colorectal cancer screening to see if we can then improve the overall rate of completing recommended colorectal cancer screening. Another example is a study that's being led by Dr. Kate Courtwright, and this is promoting palliative care delivery. This is a study that has just wrapped up really at Penn. And this is randomized on a unit or hospital level in which the intervention is being targeted at clinicians, where they are receiving a nudge to either deliver palliative care themselves or consult specialty palliative care for patients who are detected by an electronic health record algorithm who are thought to be at high risk of death. And so they can then either, like, these little schematics are supposed to be like that doctor who like got that nudge, then either going to the bedside themselves and delivering care or calling in the specialty team. Another study led by one of our colleagues in the Pear Center, Dr. Meetha Kurlan, was about improving mechanical ventilation. So adherence to one of the only sort of evidence-based interventions we have in the ICU is to deliver low tidal volume ventilation among a group of people experiencing acute respiratory failure of ARDS variety. And it was a nudge targeted at clinicians, either physicians or respiratory therapists or both, depending on sort of, I think, the arm. And the goal was to see if those patients then ultimately spent more time receiving guideline recommended modes of mechanical ventilation. And then the fourth one is this is the only one that I'm telling you about that's like not related to Penn. This was a study done where they wondered if the method used to visualize the vocal cords when you're going to intubate someone emergently would have better or worse outcomes if you either made people use direct laryngoscopy, where you like visualize with just your eyes and the tool, versus the kind that has a camera on it. So you don't necessarily, it sort of changes what the dexterity is that you need in order to get the tube into someone's trachea. And there's been controversy as to like which of these is better. And so they randomized on the patient level to have the the clinician either intubate using direct or video laryngoscopy. So all of these have some common features, and they're obviously all very different. So I just want to pause. We don't necessarily have to all start talking about it, but just thinking what is a little bit different potentially about these study designs than that classic pattern I showed you. If anyone does want to say anything, they can, but we don't have to. I'm willing to keep talking to. Adina's got her hand up, so I will welcome her.
Possibly waiver of consent?
Totally, yes. We'll spend time talking about that. Yeah.
For three of these, they seem like they're not medical studies, they're social science interventions.
To
So
some
they're-
extent, right.
They're not really sort of natural science.
Or I wonder if what you're getting at is like, what is the actual intervention?
Right. But it also might be something that knowing about it means the intervention changes the intervention.
Oh, so thinking about like scientific validity, like, so if you like knew one way or the other that this was a study, maybe that would influence the way that the study would actually, like what would actually happen.
Right,
Yeah.
sort of like nudges, yeah.
Yeah, Scott.
Say for at least 3.5 of the trials, Siobhan's maybe on for half, the intervention is directed towards clinicians, not
Yeah.
patients.
Yeah. Like, because so I think thinking about, yes, exactly. So all these things are exactly things we'll talk about. So the first one to talk about is, and you guys sort of, this is related to who is receiving the intervention, but also like, what is the level of randomization? So in 2 of these studies, like in the middle, the randomization level is at the level of a health system or a facility or a unit or a ward, right? So it's not like you're randomizing on the individual patient level. A patient is assigned to whatever randomization arm they're going to receive based on where they show up. So if that person, say, for example, you were going to offer them to participate in this study or not, and the entire unit or the entire hospital is receiving that intervention, what is their choice or what is their option if they don't want to be part of it? Like to get up and like walk to the hospital down the street? Like not really, right? So that's not really feasibly an option for them. Like, so the randomization level, I think, matters here. Who is the participant? I think is something to think about. Like, where is the intervention being targeted? This is to Scott's point. So there are obviously patients involved in all of these studies, and the outcomes that we're interested in are on sort of the patient level or groups of patient level, but the interventions are targeting clinicians. Like, so there's nudges towards clinicians, as you brought up. There are other behavioral interventions towards clinicians. And so how do you conceptualize who is the participant in the study? Is it the patient? Is it the clinician? And like, what does that mean about who you're going to return results to? And then one other thing to bring up, and this is not unique to pragmatic trials by any means, but thinking about sort of the context of considering returning results and the context in which these studies were performed. So at least in 3 of these, the patients are being identified by virtue of essentially having a very high risk of morbidity and mortality. Or because the disease experience they're going through is one that carries with it a high risk of morbidity and mortality. And so returning results to a population of whom perhaps 25 or 30 or more have passed away is different. Like, who are you returning the results to? And thinking about the impacts of that. All right, so to whom should results be returned? I'm just curious, like, do people have opinions on that? As we've talked about that a little, an opinion that they're interested in sharing. Tamar.
I can tell you to whom we return results in various kinds of studies. So for those that participants are ideally still living, we return them to those folks. In other cases, we've returned them to like the address of the person who was enrolled, who may no longer be, around. One of the challenges that we've run into though is that like in those cases, oftentimes returning the results was not part of the original plan, right? So now, like when you think about it ahead of time, you can consider, asking like, would you like to receive the results? Where did we send them? Which can make things a little bit less like icky, for lack of a better word.
Yeah. And sort of implied in that, right, is if you're asking someone if they would like to receive results, they presumably know that they're in a study. which may not always be the case, right, in some of these types of study designs. All right, so I would say that there's at least 3 groups that we should think about. It doesn't mean that we should always do it, and you know, the context always really matters, but thinking about patients or you know, traditional subjects, which depending on if your research isn't inside like the walls of a hospital or a clinic, like it's not necessarily patients, maybe it's students, maybe it's parents, maybe it's other community members. Thinking about, in this context, clinicians as being an important stakeholder group, right? Because they often actually are the target of whatever behavioral intervention might be going on, particularly when things are delivered through the electronic health record. And not just physicians, like in the other study I mentioned, it was respiratory therapists. Like there's other individuals who might be totally necessary to the work that you're doing that we should think about from a respect standpoint of trying to return results to them when we have them. And then health systems, because again, some of these larger pragmatic trials really are operating across multiple health systems. And so thinking about like those health system leaders that sort of are part of that work that also obviously should be likely already invested in the results, but would certainly want to know. And so thinking about those as like different audiences for whom results would maybe need to get returned to. All right, this got brought up earlier, and I just want to come back to it because this is a super important part. So pragmatic clinical trials very often, not always, but often will utilize either altered forms of consent or waivers of informed consent. And there's really good reasons why this is true and has been practiced for a while. So again, like I said, many pragmatic trials are looking at different interventions that are already part of standard practice. So it's minimal risk in terms of, or at least minimal incremental risk compared to what would happen in usual care. And or they're using routinely collected data that's not really being collected outside of what is already happening in the health system anyway. It could be very impractical, if not impossible, to obtain consent. So both for the piece that a patient might not actually be able to get up and leave a hospital. Also in the context of the study where they were looking at the intubation technique, it's not really a good time to ask someone when they're in acute respiratory failure, like, would you mind if we used like a camera or not a camera? Like, that's not going to work, right? That's just not realistic. Bless you. Jeopardizing the scientific integrity. So if your intervention is a nudge at either a patient or a clinician, who knows, if you tell people that this is the study that's going on, that could influence the way that the study is going to be performed. So it might not be possible from trying to really generate important knowledge to do it that way. And then again, we talked about interventions occurring at the system or clinician level, and so not necessarily being able to get consent from individuals for that reason. So all of this is true, and this has been like, this is sort of known about pragmatic trials, but the consequence of it is that participant patients typically don't know that they participated in a trial. And so therefore, delivery of results often is going to be equal to notification of participation, which makes it a little heavier potentially than returning results to individuals who voluntarily participated in a study or the loved ones of people who voluntarily participated in a study. And so the implications of this are different, I think, than if you're talking about studies in which individuals actively participated. All right, this next study is going to be overkill. This next slide. Oop, they've just kidding. All right, so should they be notified of research participation? We talked about that. So should they be notified of research participation at all? I jumped the gun a little. The next slide is overkill. Notification without consent can erode trust. You all know about this, like Tuskegee syphilis study. This is like totally on the other end of the spectrum, right? Where it's not just that people weren't notified they were in the study. It was like horrible practice, like truly egregious stuff. But I wanted to bring it up just because there's a huge, this isn't the only time that people have been involved in studies that they did not know about, but this sort of history looms. It also gave me an opportunity to give a shout out to Peter Buxton, the late Peter Buxton, who was the whistleblower of this study and who was my primary care patient for years when I was in San Francisco, and is an amazing, wonderful person. And like I said, pragmatic trials are different, right? Like this is not relevant to that, right? Like we know what we're doing. It's all usual care. Like we're not going to make any poor choices like were made decades ago. We're comparing validated interventions that are already part of usual care. It's minimal risk. It should be fine. And often like we're studying these clinical decisions that patients and families aren't really part of necessarily anyway. They're not like value sensitive decisions. Like again, do patients have opinions about direct versus video laryngoscopy? So they're not really going to care. Wrong. When studies have been done to try and understand what is patient and public perception or opinion about this, generally what has been found is that post-study notification of participation in a trial is the least acceptable to the general public. So this like graph that I'm showing you here is from a nationally representative survey where they describe different types of pragmatic trial designs, and they asked individuals about the acceptability of various ways of returning it. The point here is to like just note where the orange arrows are. Post-study notification, that's what POST stands for, were the least acceptable to the individuals that were surveyed. So finding out that you were part of a study that compared two types of surgical rods was something that people generally found unacceptable. Two types of needles, people didn't like that. And then when they also asked those same individuals about how, like, so if you found out you've been part of this, like, tell us about how you trust in the research team and the medical team after this. Those two methods, post-study notification, were the only two that were associated with sort of an increasing amount of decreased trust in the health system. So that's disappointing. And it's been replicated. There have been 5 nationally representative surveys that cover around 10,000 US adults that have examined views on the approaches for notification and consent for pragmatic clinical trials. And in general, even though it is not really feasible based on the study design, the most preferred way is traditional written consent. Streamlined consent or sort of like alterations of consent, like getting it after the fact, or maybe making it like a quick verbal one and then following up, like people find that often acceptable. But when you ask people about their opinion, they generally find just notification, like there's a study going on here at this hospital, you might be part of it, you might not, or post-enrollment notification. Here is a letter coming to your address saying your loved one, you or your loved one was part of this EMS study, generally unacceptable. And there have also been more deep dive qualitative studies, like one recently, in which there was a lot of effort spent not just deep diving into the why, but educating people about pragmatic research, what the values of it are, what the constraints are of it. And while there's sort of general acceptance again for alterations of informed consent, there was low enthusiasm for no notification. So even when spending time like talking about what pragmatic research is, most people are saying like, yeah, no. So arguments have been made against notifying individuals enrolled in trials that utilize waivers of consent. So I'm leaning really here heavily in the next couple of slides on work by Dr. Stephanie Moraine, who I had the pleasure of meeting last week at the Impact Collaboratory meeting. Had some really nice conversations with about this. So I really appreciate her time in helping me think through this. But some of the different reasons why you wouldn't notify an individual of the participation are going to overlap with why you might not be able to then return results to them. And so these are some of the arguments that she and her colleagues have sort of identified as being barriers to just letting people know that they were in a study. And so when we think about these in terms of big categories of how they pertain to arguments against returning the results to PCT participants, we're going to have sort of 3 big buckets. So there are these consequentialist-based considerations. So thinking about what are the downstream implications. And so the idea that there might be downstream harm to patients and families. So not trusting your healthcare institution, I would say, is a harm. Like that's not good for people to feel like they're being potentially taken advantage of. That's not going to improve health outcomes if people are afraid of us. Downstream strain on clinicians who weren't involved in the study. So if an individual receives a notification from their health system that they were part of a study, where are they going to go with that? They might go with it to their primary care doctor, who is already, you know, overly burdened with all of the many things that we expect our primary care doctor to do. Now they're going to try to interpret some pragmatic trial done across the street that this patient was part of. And so what might be that cognitive and time burden that might fall downstream in the health system? The next category is just the logistical and the practical barriers to sharing. And so, you know, the size and the scope of pragmatic clinical trials can be massive. Scott, how many people are going to be in Compass PC?
78K.
78,000. Like, how much would it cost just to mail a letter, right? These days, what is it going to be, like 38,000? Something like that, right? So it's like crazy when you think about like just the size of, even if you were doing like a low touch notification. And this was brought up, like, I think kind of Tamara alluded to this, like a lot of times we don't think about this even until after the fact. And part of that is because there's not really a lot of funding and or institutional support to promote these practices. It's not usually included in most budgets. if it is included in the budget, like Corey, for example, like I think requires that $2,500 is allocated to this. But if you have a study of 78,000 people, you're certainly not going to be able to deliver individualized results to that population for that budget, probably. And then institutional support. Like, unfortunately, it's not, I haven't seen yet an opportunity to share with sort of leadership of like, and how have you returned the results? Thankfully, there's been like a more attention delivered to dissemination more generally of your work, right? Like in order to demonstrate impact. But I think this piece of like returning results to participants, if it's thought of at all, it's sort of underneath that umbrella. And then privacy and confidentiality considerations. Some of the ways that these trials are designed is such that you're not collecting unique information about the participants other than, again, what was already collected for routine medical care. So you might not have their address, their telephone number, their email, and you might not have, and even if for some reason you have that, it might not be linked to their study outcome if that was relevant in any way. And so asking to obtain that information from your health system partner in order to return results might actually change the sort of risk of the study because it was confidential information that you otherwise wouldn't have needed to have. So there's that piece of it too. And then again, thinking about those types of studies that are done in populations in which there's a high risk of death, like we blast it out to a family member that may or may not have known that the person was in the study or what happened. And so there's a lot of like questions around that as well. All right, okay, so here I want to dive into some qualitative data that was shared with me as courtesy by Dr. Moraine, in which they had done some interviews with people who engage in pragmatic trials. So researchers, health system leaders who are actively engaged in pragmatic trials, and they asked them about sort of their experiences either with returning results or sort of never returning them. There are a couple like key themes that came up that I just want to highlight. So one of the barriers to returning results that her and her group found was this desire to avoid undermining trust. And so when they had brought it up, this research team to the IRB was like, do not do that. This is going to just result in a huge backlash, like that article I showed you at the very start, right? Where they're going to, the individuals who receive this are not necessarily going to receive it well, and it's going to cause more harm than good. Logistical barriers. So you really can't hit these enough. So cost, difficulty. It's a good idea in theory, and like maybe it would be good if people knew about this, but like the cost of this, like yikes, like it would just be not really possible. And then thinking about sort of like, again, that barrier of like the timing. So like some of these trials take years to be completed. And so then you're going to return those results like years later. Like, what does that really look like? Where are you getting the personnel to do that? It's like 600 people, and that's nothing compared to some of these studies, right, that have, you know, orders of magnitude higher than that. And so this person said it was just barrier after barrier after barrier. And so not really something that they were able to overcome. And then I found this theme to be so interesting, but it's this idea that even the information that's shared might fail to meaningfully inform. And this quote is like a little bit tough, but I really feel like the essence here is like one that you like worried about, again, harming people, because going to them and maybe trying to explain this trial just might not work. And like you're asking to confuse patients, like you might be doing more harm than good. And then this is interesting. Like this is a quote from an individual who has experience with returning results or attempting to return results from pragmatic trials, in which they were kind of surprised that people didn't seem to care. And so, you know, we're so worried that people are going to care so much, like on one end of the spectrum, that they're going to get angry and distrust us. But there's also probably plenty of studies in which people are going to be like, right? Particularly depending on what the results are of the study. And so one point I want to talk about, and maybe others will have some like thoughts on this as well, is that there really is this inherent tension between these expressed preferences of patient and public around like generally thinking that comparative effectiveness research is a good thing and a desire for individual informed consent. Like those things don't totally align. And even with dedicated education, so I mentioned that one qualitative study that was done in ICU survivors, that's not the only one. This JAGC reference on the bottom, they did these like community workshops where they brought people in and they spent a ton of time explaining like how comparative effectiveness research is accomplished and like what minimal risk means. And people were kind of with them, like, yes, like agree, like that seems valuable. I can see why it's important. And I think I should be able to give consent or not every single time someone wants to use any of my secondary data. Like my data in the electronic health record, even if it's not tied to me, you should have to tie it to me to ask me for my permission. And think about how many times we do research that way all the time. Like we've sort of generally accepted, right, that that's barely even human subjects research if it's separated from the identity. And so overall, when you get public opinion on this, you get this general approval and concept of a comparative effectiveness research, pragmatic trials, needs for alterations in informed consent, a desire for the medical and research system to exist and advance knowledge, but disapproval of any kind of general notification or post-enrollment notification. And those are really, like, I think, in conflict with one another in a way that I'm not sure what the solution is. All right, so all that being said, let's decide that we do want to entertain the possibility of returning results to individuals who participated in pragmatic clinical trials. How should we do it? So I've sort of tried to think through, like, sort of what are the different ways in which it could be done. And, you know, you can always do individual results versus aggregate results. In the context of these types of trials that are looking at health system interventions, individual results are very difficult probably to interpret and not potentially meaningful. So most of the time we would probably be talking about aggregate results. Like, what did the study find? General versus targeted. So general, what I mean here is, like, you could just make announcements to all of the people that possibly are part of your community. So you could do it through your hospital newsletter that goes to anyone who's related to the hospital. Or you could do very targeted. You could send an electronic health record message to every single person who was actually enrolled in the study, right? So you could target that message. So it's not just we've done this study, this general notification, it's we did this study and you were part of it, or your loved one was part of it. And then what I termed is like passive versus active. So passive being like, there are posters somewhere. People might walk by them, they might not, but they're there. And then active, where maybe it is that like directed message. So like a mailer that goes to a specific person's address or even a specific community's address, where you're actively trying to make sure that you have a little bit more of a responsibility that they've actually received the message that you sent. And you could imagine that if you were to think through all of these, depending on the specific context, whether or not it was what you would want to apply would vary. Coming back to this example I showed at the start. So this was that study where they compared in emergency medical services, ketamine versus Haldol, and they decided to go with the general letter. I don't know all of the language of that letter. I only know what made it to the lay press article, but I would say maybe this was not the best choice for this context. And so we can learn from that when we think about what we might want to do. Is there any data for how results should be returned, how participants like to receive them? Yes, but just so you know, it mostly comes from more explanatory trials. And so in this case, ICON 8 was a phase 3 RCT looking at different chemotherapy. So people definitely individually consented and enrolled in that study. And then afterwards, they had a sort of embedded study that was cluster randomized based on trial site of how they would offer for participants to receive results. And that study was called Show Respect. And what they compared were sort of 3 different types of interventions: enhanced web page versus basic web page, a mailed printed summary in addition to website access versus not, and then an invitation to join an email list to get trial updates like sort of throughout versus no invitation for that. And what they found here was that people kind of want all the options. They essentially found that adding that opt-out mailed printed summary plus the web page like just resulted in highest satisfaction. Other things that they looked at, like comprehension, stated willingness to participate in another trial, none of those were different across their different arms. But people expressed at least that they kind of liked having all the things. But again, very different to hear about, to sort of like measure the impact of these in a study that is all people who knew they were part of it and had voluntarily participated in it. What is this? So I was on service the other weekend. I was walking through the lobby at Hub and like this was going on. So these were all like quality improvement / research / quality improvement research, like, you know, kind of like in the middle of that, of posters like up in the lobby where our patients' families go through, patients going to outpatient visits go. So these were all up for people to see. And if they wanted to like take a peek and read, they were not targeted towards they were scientific abstracts. So they were written as the scientific abstract is, or scientific posters, but they were there. And I was like, I don't know, like, what is this? What is this? I'm not sure. This is probably targeted for us, right? Like there was probably like a session here and like invited people like us to come and see them, but they were there too. So maybe it's like checkbox. I don't know. What's this? This is a really cool study that my husband's a co-author on. So disclosure. But this was, this is the COVID watch study from a few years ago of when people were randomized to getting part of like a text message intervention and a pulse oximeter to see if that like improved their outcomes after COVID. And it was a very impactful intervention. It worked. And so Penn sent out this cool newsletter to everyone. Like, that's great. Is that dissemination? Is that results return? Like kind of this goes out to Penn Medicine. I don't know how you get on these listservs necessarily. Like I know we all are on as like employees, but like it's anyone can sign up for the listserv. So maybe that's community notification. What about this? What about getting articles in the Inquirer, right? So broader audience potentially than who's getting the Penn newsletter. But what kind of studies are going to get this awesome press? Not the ones that are negative, right? Like, and so there's, this is one way maybe that you can try and like, is this dissemination? Is this results return? Like, if you're doing like a sort of passive general approach of just sending something out, like maybe this is results return, or it could sort of seem like it. But again, like who knows who's really seeing it or not. And this is going to maybe work. Like maybe the Inquirer wants to thankfully publish these really cool things that Penn is doing that are improving outcomes for people. But all the studies that end up sort of null with like really interesting discussion sections in their papers, like they're not going to end up in the lay press probably. All right, so when we're considering like a method of results return, I think that there are a few things that we can think about. So what is the study context? I do think the study results really matter. And in some ways, you don't want to say that you're not going to return results if it's a negative study, like you want to return results all the time, but you've really got to think about how you're going to do it if it turned out one arm fared better or worse than the other. Communicator, who is the message coming from? Is it coming from the study team or is it coming from the health system that the person might already have a trusting relationship with to some extent? I think that's something that's also worth thinking about. The institutional plans and next steps. Those should probably, especially if you had a positive study or a study that has results for which there should be some next step, you might want to think about what that is and talk about that with your health system partners in advance so that you can answer, like, so maybe that information is shared up front and or you're ready with it if people reach out to you following. And then scope and cost obviously need to go in here. And this is where it comes back to sort of what Tamar had said really early on, like maybe we should be thinking about this at the beginning of a study and not just when we're closing out the IRB. And for the sake of time, I'm going to go through this a little bit quickly. I thought we could, think about how we might differ our approaches like with these types of studies and or with these types of studies. And so those were each like different of the pragmatic examples that I showed you guys. So we have given some thought to how one might return results for these two trials. And we've thought about how we could do it in such a way that we could learn from it so that we can help build some of that evidence for how we ought to be doing this in the future. And so we proposed some empirical work in which we would use these two studies to figure out what are some of the options, how are they context different using mixed methods work with individuals affiliated with the studies, like on the study team, patient caregiver advisory groups, and individuals who have work in pragmatic trials outside of these specific studies. And then we wanted to test interventions or methods of returning those results to individuals who had been enrolled in these studies. And our hope was that we would measure individuals' trust, their willingness to participate in future research, and then their comprehension, like which methods like actually either helped explain it better and then to understand if comprehension sort of mediates the trust piece. Because you can imagine if you fail to explain the whole thing really well, like maybe trust is going to be worse than if you'd done as good of a job as possible to do that. We're still waiting to see if we can get this one funded. All right, so conclusions. So plan for return of results and dissemination from the start. Engage patient and family advisors and health system partners early. Don't forget about the clinicians or whoever else it is that's sort of really receiving the nudge or the intervention, because those people actually should also be given results so that they know what their work is contributing towards. Leverage institutional resources when possible. And I just wanted to make a plug here for the amazing Chive and Pair Joint Research Practices group that has done some incredible work in trying to give us all guidance as to how to communicate with individuals who participated in troubles. Shout out to Adina, who's one of the leaders of this organization, of this group. And then institutions should have an active role in the planning and the supporting. Like, this should be sort of part of their responsibility if they're going to undertake, they're going to, you know, allow for their community of patients or families to be part of this research enterprise. And those institutions, those health systems should also be part of thinking through this process. And then, you know, we still have more questions than answers. So guidance, and ideally guidance that's built on evidence, is sorely needed. It's really hard. Logistical barriers were one of the main things that came up in Dr. Morane's work, but I don't think it's impossible. And so if we think this through and we do it right, we might be able to build trust and confidence in our health system so that we can continue to do great work for our patients and their families. That is what I have. I want to thank some of my mentors, Melanie Botti, who's the research coordinator on my team, Health Doing Things, the folks who I'm hoping to collaborate with on that project I shared. And again, Jason, Emily, and Stephanie. I've talked about this concept with them recently, and especially Stephanie, who was so kind to share some of that qualitative data. I welcome questions and comments now.
Love that Austin's not in the picture.
Well, he was here, so, and Austin.
And Austin, yeah. This is great, Katie. Thank you so much. And I would be remiss to say that the shout out is to many JRP members here, including Jasmine Silvestri, who leads our dissemination subgroup. And I think it's worth mentioning that we've been working with the IRB to collect data around what people are what people are reporting to disseminate after studies. And they just reviewed 900 studies, and we're going to be looking at the data in partnership with Rachel Cohn, who's a faculty leader at the JRP. One thing they're hoping to do is to do some interviews embedded within trials about dissemination. And so I think that's a nice partnered work or complementary work to some of the things that you've been talking about here. And so we're looking to embed that work into existing trials. And so anybody in the room is interested in learning more, find me after the talk. But I mean, a lot of us are thinking about this at Pair and MSHP, and it's, as somebody who thinks about this a lot, I feel like you present it in such a, I was like, oh, right, like there's so much tension. And I think especially around the pragmatic trial design, I don't have a question. It was just more of a glaze. Thank you so much, Kate.
Thanks, Adina.
Yeah.
Yeah, I would be so curious to know when you do that review, like what proportion of individuals who are saying, oh yeah, here's our plan, we've got one, it's a thorough plan, are from trials in which individuals were individually consented versus not. Because I think for individually consented, it's a little bit, it's not that it's easy, but it's definitely a little bit easier than if they were not.
Katie, we'll alternate questions from the room and online, and just sharing one from online. There's actually a bunch coming in. This one from Christine Yonke. Do you have any data regarding patient satisfaction about result return? If there is a box they can check on their informed consent form about whether they would like results, if any. Also, I think it's important to state in the consent form that there will not be any results, biobanking, natural history studies, other studies, the last et cetera.
Yeah, that's a great question. I don't have personal data that I've collected, but that study that I shared that was the Show Respect study, you know, they had planned to do that second study as part of the ICON 8 from the start. And so when they were enrolling individuals in ICON 8, they started already implementing the interventions of Show Respect, one of which included that, like, basically, do you want this website? Like, and then you were going to get randomized to either get the basic versus the enhanced. And then the second piece where there was sort of obtaining of participant preference was around if you also wanted to get that email. And what they had presented in their results was that 9 of 10 individuals signed up for the website at least. So 90% they were thinking wanted results, but almost no one signed up for that. I want that email real-time update. Which is kind of interesting. And this also might be very study specific. While you're actively going chemotherapy, knowing if the agent you're on is enrolling enough people or not, like, might be cognitively different than wanting to hear what the results are at the very end. And then just agreeing with the comment about how if you're asking individuals if they want to receive the results, you should stay true to that, whether they say yes or no. And then of course there's tons of research designs, right, that are not including immediate results, and that there is a separation of data from individual identification, and that those linkages like should not necessarily be reconnected, particularly if that's not how the study was approved. In the back.
This is super interesting. Thank you. I am not someone who does clinical trials or research of this sort, so forgive me if this is basic. I'm like hung up on who counts as a participant and how. Like people seem to be participants in very different ways. Like the intubation example, it seems like the people who are really participating are the clinicians who are trying to actually place the tube. Like I can't even really imagine what you would tell a family member or a person, like you had the tube placed in this way or that way, or the screening, getting people to do the colorectal cancer screening. Again, like say you were nudged in this way, like I just getting my head around actually what you would even share in these kinds of examples. And they all seem quite different in various ways. It would be hard to have like a recommendation that's just across the board. But so I don't know if that's exactly a question, but like I guess very concretely, in what way is somebody a participant in the intubation example? Like, what would you tell somebody actually about the results and the way in which they were studied?
Yeah, I think that there's like 2 points to what you're saying that I think are important to break. So one of them is just your expressed sort of confusion around who's a participant or who's not is like, you are not alone. And in fact, like arguments or discussions around that language and who it should apply to in various studies, I think happens frequently and might differ based on which IRB is reviewing a proposed research protocol. I saw Vanessa kind of nod her head to that earlier, and I think she has like experience probably discussing this with some of the partners that the Pear Center has done trials with. I think it's sort of an outstanding question. And I believe Dr. Moraine and some of her team actually has some guidance that's going to be coming out related to that, like who should be considered a participant or when should a clinician be considered a participant? Because I think that is an outstanding question. Now, then when you're taking the piece of like, all right, well, how do you explain to someone the results? You just bag the word participant entirely. I think you have to really kind of lean on plain language. And like, if you're trying to reach like a broader community, and I think it would be, this is like off the cuff, but it would be something like, while you were at University of University, a trial was going on to look at the differences between A and B. You were part of this study. I don't even know if you're going to necessarily divulge like what arm you were on, but maybe it was like, and these were the global findings of the study. And same thing to clinicians, like while you've been on practice here, like you might have realized that all of the crystalloid being stocked in the emergency department was plasmaloid. And then a month later, it was all normal saline. That's like a very in the weeds specifics about a different type of critical care pragmatic trial that recently happened. But, you know, like I think you just tell them the results, not necessarily getting into the weeds about with them. So, yeah.
One more from online, probably our last question, because we do have a hard stop at 1. From Lexi Ballman, what are your thoughts on engaging communities while developing research proposals to understand how they may want to receive results? Thinking of the Coria and their patient advisory boards of sorts that might be utilized.
Yeah, I think that that's absolutely necessary. Like that if you don't engage communities along the way, we will probably do it wrong. Now, that doesn't mean because you set up your advisory committee and you ask them the question once or twice, you're going to necessarily do it right. Like, I think we don't really know for sure. And what is right and what is wrong? What are the implications of doing this? I think those are all sort of outstanding questions. But I will say I was reviewing, so I have the good fortune of being involved in that 78,000 person trial that Scott and Kate Courtwright are leading. And I was reviewing from the original proposal, like what the description is of how results are going to be returned in there. And it's kind of like, it's like a little bit like mostly just general dissemination, flyers, newsletters, like things like that. And we have a patient and caregiver advisory group that we will engage with more thoroughly, I think, as we move along in that planned like long trial. And so I'm looking forward to getting their input on that over the next 4 to 5 years.
You might be the only person who ever read that.
It's possible.
We have to end, but thank you, Dr. Auriemma, for